Good afternoon, everyone. I'm Sarah Muntel. I'm from the Communications Committee at ASMBS. We're just going to go ahead and give people just a quick second to log in as we wait to start our great, fantastic webinar this afternoon. All right. Okay, well, I wanted to thank all of you for joining us today. Our webinar is from San Diego to you, a conference recap from 2024. So I don't know how many of you were able to go to the annual meeting, but what we have done is we would like to take some of our top sessions and bring them to all of you today in a quick, short snippet so you can really get a full feel of what this conference is all about, some of the key points, key presenters. So I'd like to thank so much presenters today. We have JJ Rodriguez, Dr. David Sawyer, and Chelsea Johnson, who are going to speak on their top presentations. This webinar is brought to you today by the Communications Committee. As a reminder, the ASMBS does several webinars throughout the year. So if you want to go ahead and check out the ASMBS website, you want to look on social media, there is no replacement for actual in-person meetings, as you guys probably know. So coming up in November, actually November 7th through 9th is ASMBS weekend, and the registration is going to open up very soon. That's going to be in Atlanta, Georgia. So more information to come. For others of you on the call, another event that is pretty popular and well attended is our networking sessions. So it's great to network with other people kind of in the field. So coming in September, there'll be another networking session for all integrated health members. So just some things to put on your calendar. As we start today, I'm going to turn it over in just a minute to JJ Rodriguez. We have a chat box going. So any questions that you may have, please feel free to chat those in the chat box, and we definitely will have time for questions. So let me tell you a little bit about our first presenter. This is JJ Rodriguez. He's the operations manager at Houston Medical Center for Weight Loss and Bariatric Surgery. Previously, he served as the center's clinical exercise physiologist, where he played a crucial role in developing the exercise curriculum for surgical and non-surgical programs. He's passionate about translating the latest research into practical advice that patients can easily understand and incorporate into their daily lives, which I think is something all of us are wanting to learn to take back to our patients. So thanks so much, JJ, for kicking us off today. And if you want to go ahead and share your screen, and we're excited to hear what you have to say.
Perfect. Give me 1 second. Let's set up my screens. Hello, everyone. Thanks for being with me today. As Sarah introduced me, as she mentioned, I'm a clinical exercise physiologist by training. Today, my topic is on exercise myths. And so I think this is a fun topic. All of us know exercise myths. And so I'm actually going to stay high level today and really kind of make this related to like clinicians and practitioners. I separate myths into the clinical side and actually the patient side, because there's two. I've heard them all. And so feel free to chime in the chat, like Sarah said, with any questions you have as I go through this. This is an interaction. I'll try to keep us on time and move us forward, but I do encourage, if you're on the call and want to play along, go ahead and take out your phone and scan the QR code. You can kind of go with me through the slides and engage with me a little bit. If not, I'm going to move forward pretty quickly, okay? So scan that right quick and just log on. Once you get logged in, you're going to see my presentation probably on your phone. You can give me a thumbs up if you're in. And then I'll move forward. So I'll give a few seconds to see some thumbs up. So I got 3 on the call. I got 4, 6. I got, 8. See, I never know on virtual presentations because I don't see people. So this is really nice to see some 8 people participating. So, all right, let's get moving, guys. So exercise myths, as I mentioned, one of the biggest barriers that I find with exercise is it's things that we've heard in social media, and what a lot of times we're seeing is the sexy things of exercise. And today I want to present a little bit of some research and one of the common myths that we see around physical activity, and then how to translate that to your patients. The questions I'm going to be posing today actually are more related to what I've heard clinicians say. And so I want to break through some of these because I know we have some clinical team members on the team. This is really important. The verbiage we say matters. The patients are going to hear it, and then they're going to make an assumption or story in their head whether they can or cannot perform the activity. And so what we say plays a big role in their actions and moving forward. So let me ask general question. You can put it in the chat or use the Mentimeter on your phone right now. What is the hardest part about physical activity? You personally. Take a moment to answer that quiz. Yes, ma'am. Susan in the chat says starting. Anyone else? Give me some feedback. Inertia, time management. There we go. We're seeing some scheduling, getting started. Yeah, time, right? Time is the essence. Time is the thing you can't get back in life, right? So let's look at this for a second. This has actually been studied multiple times in qualitative literature, specifically for our bariatric patients. And what's unique about this, and this is the phrase I use with patients all the time, is that emotion drives emotion. And as clinicians, if we can get that in our concepts and in our teachings, we're going to have better outcomes of helping motivate patients to be active. Okay, so let me tell you what I mean by this. Time in studies qualitatively looked at with post-bariatric patients, this is replicated across 4 or 5 studies. I'm giving you one that's probably the most unique that I found interesting. Time was the most frequently cited study aspect. But here's what they found in that. When they dug deep, when they asked more questions, there is a higher order of barriers that are both internal and external. Meaning, although time is the most frequently cited, when they powered it, it didn't have the most value for them to actually stop exercise. There were other values that had more weight, so to speak. So 78% of the barriers actually had more value that were related to motivation. Motivational factors were a primary reason why we didn't begin exercise. Yet most of the time we related it as time. Okay, so making sure you connect with an individual or a patient or yourself as to why you're doing what you're doing is a pivotal piece in starting or beginning your physical activity. A lot of times time is the most common thing, but then I always reframe and say, why do you want to be active? You know, what is the driver behind it? So getting to the emotional side of this will drive emotion. And so it's a real big piece because I think a lot of times we chalk it up as time. Time is the biggest factor. So question, let me just quiz y'all. I see, oh, look, we got flags and penguins on here. 6 people ready to play. I'm going to start the quiz, guys. Quick question for y'all. Y'all can play along. Got 11 players in. Nice. All right. Knowing this, knowing that emotion and time are those factors, give me your thoughts on this. Whoever gets the most points, whoever answers quicker gets more points. When studied, what is the hardest part about performing physical activity? Coming up on your phone now. Let's see it coming down in 5, 4, 3, 2, and 1. Let's see who's got it. Yeah. Yeah, so internal emotional factors is what I would say is probably the biggest driver, although reported time is the biggest driver. So keep that in mind. Time is a factor. There's no doubt. Time management with kids, with families, with work, with life that happens. But there's a bigger factor that's actually weighted higher when studied that's helping drive emotion or motion. So something to think about. Let's move on. Leaderboard, see who's winning this. If you're competitive, you'll like this. Tom, congratulations. You're winning right now, but not for long, my friend. Let's move forward. All right. Exercise for weight loss is myth number 2. All right. So let's talk about weight loss and exercise. Let me give you a quote. Who has not said this? Any person you meet where you talk about your health, this is a phrase that I've heard. It doesn't matter if they're an exercise professional. When we're at ASMBS, the most common thing, I get people coming up and asking questions about exercise. I'd hear this all the time. I need to start exercising again. Everyone falls into this trap. My question to you, the clinicians and the patients, is why? Okay, so what is your intent to exercise again? Because here's what do I know? Here's what we know. And I ask this all the time. I ask you personally right now. How many of you began an exercise plan with the intent to lose weight? Okay, now how many of you began an exercise plan with the intent to lose weight, busted your butt for a week, and then at the end of that week, weighed yourself? And were you satisfied? Okay, 95% of the crowd typically is going to say no, and especially dealing with our patients. This is complicated. Let me give you a quote. This is really interesting. If you're unfamiliar with Herman Pontzer's work, I'd highly encourage you to go read his literature and pieces. He is one of the top leading researchers in human metabolism. Most of his work is done at the Hadza tribe in Tanzania, looking at total daily energy expenditure, how many calories we burn at rest. He studied tribes that are still nomadic and still very active in nature. The tribe he studied gained over 150 minutes a week of activity, 150 minutes of activity in a day. Now, that's our recommendation in a week. So these guys were really, really active. What we'd expect their calories to be out the roof. Okay, so what he found though, cool quote here is the bottom line is that your daily physical activity level has almost no bearing on the number of calories that you burn each day. That's from his book. This is from the leading researcher in metabolism. When someone like that, and I see in a publication says that, my head turns, my head spins, right? I got to look into it. I got to research it. I got to figure out what's going on. Okay, so pretty much since the 50s and up to now, past 10 years, the common model we know is what we call the additive model, right? We know resting energy and expenditure, daily activities and other activities make up our total daily. And then everything else, physical activity, what we call PAVs or physical activity vital sign, energy expenditure can be additive. You do more exercise, you do more work, you burn more calories. It makes sense, calories in, calorie out. That theory in that model is still effective. What's complex about this, though, and what he published with these tribes and these indigenous groups is that actually at the high levels, it's constrained. It actually begins to taper out as to the total calories you burn in a day. Now, I will say most of us are not hitting those upper echelons, but the idea to begin exercise for weight loss goals may not be the best approach, especially when you're setting goals for your patients. Okay, so let me actually show you publication. This was a meta-analysis out of France, 12 systemic reviews, 149 studies looked at. This is also duplicated in multiple studies, meta-analysis, when we look at body composition changes with bariatrics. Exercise for weight loss is minimal. Okay, now we can say it's significant based on the studies, but keep in mind what's deemed significant is 1.5 to 3.5 kilograms. It's like 8 pounds. Okay, what also is unique, if you look at these studies individually, they're anywhere from 6 to 12 months in length. So the idea that you're losing a substantial amount of weight from exercise in a short amount of time is just not seen in the literature. Okay, so what is seen though is HIIT, moderate intensity. So whether you do high intensity or low intensity, the benefit almost had no difference. Okay, finding an activity that you stuck with was more important in the consistency of the workout when it came to all-cause mortality and weight maintenance. Visceral fat improvement did improve regardless of total weight loss, which is a benefit for exercise. Resistance had no effect on weight loss alone, but was pivotal in maintaining lean body mass, which is we know is a crucial piece in any weight loss training. So exercise has a ton of benefits. There's not many disease states that it doesn't benefit, except when it comes to substantial weight loss that we may perceive that we want out of exercise, right? So reframing those goals is extremely important that we know what to expect. Okay, question number 2, 9 players in. Let's see what we get. Oh, did I skip it? All right, here we go. 12 players, 13 players in. Which statement is false? This is an exercise question based off what we presented. False. False statement. You got 5 seconds. That's correct. High intensity interval training burns more fat. Yeah, so this is a fun one because this is actually a myth in itself. If you go on social media, you'll hear influencers tell you that you need to do high intensity interval training. It burns more fat. And from an exercise physiology standpoint, it's almost 90 to 95% carbohydrates that it's burning. So from an actual physiology standpoint, it burns more calories. And that's a very specific thing to note because a lot of times high intensity interval training is not that fun. It's very hard. And so if you don't want to do that, remember, it's not a necessity for weight loss. It's more about framing it to what you're capable of doing, right? So keep that in mind. Okay, let's see who's up. Let's see if Tom has kept the lead. Ooh, barefoot. Sarah is now at the top. Oh, hey, Sarah. Awesome. Moving on, guys. What about keeping the weight off? All right, let's talk about maintenance here. This is a fun one because maintenance exercise in publication seems to be beneficial. Now, this is questionable, I would say, but there's good literature to kind of support exercise plays a role in maintenance. Okay, so what we've seen in the literature for this, it's very variable. But what I want to point out is a study that was performed in the University of Kansas that I think is a really unique study that's going to lead to more publications around maintenance in the next 10 years. What they found was that there was no difference between 150 minutes of exercise, 225, and 300 minutes of exercise. Now, why those different categories? Because WHO, ACSM, NIH, and American Heart Association all have different values when it comes to the total amount, what you should be performing to help with maintenance of exercise. So the question they were trying to solve for is these, when we put individuals that were highly studied, getting those certain amounts with behavioral change or without, did it have an effect on individuals who lost weight? What they found, as we probably knew, but it's published now, behavioral intervention was key distinction in the lower volume of weight. So is it possible to maintain weight with 150 minutes a week? Yes, this publication showed that, but it had to come with behavioral intervention. Okay, so they had classes that they attended virtually. They had support groups that they attended as part of their routine. So could exercise alone help with maintenance? Yes, but it's at the high levels. We're talking about 250 to 300 minutes a week. That's like an hour a day. Okay, a lot of times patients may not be able to perform that. So the unique part of this study is that they did note that they're uncertain if the behavioral intervention is the key driver, but it was the one distinction or thing that was pulled out. So keep in mind with maintenance, exercise can play a role, especially at lower levels. A lot of times we may not have the time nor we want to perform 300 minutes of physical activity. So 150 to 225. Let's get to question 3, guys. We're coming in. What is the recommended exercise volume that is beneficial for keeping weight off? This is a little bit of a trick question. Three seconds left. Yeah, so yes, 150 with behavioral intervention. Technically, that 200 to 300 is AMA's, American Heart Association's recommendation. That 300 to 450 is WHO's recommendation. That 200 is ACSM's recommendation. So all of them are, there's good publications to support each one of those individual volumes. But with that being said, it's still a researchable area. I think it can really all be a very factor, specifically with benefit to behavioral change. Okay, so that was a little tricky one. Chelsea and Sarah chimed in there, and Sarah's still up. Chelsea is so second. Okay, the last one. This is probably the most controversial one I had at the conference. And I think probably could do a whole talk just on this one. It's growing muscle. Okay, I started exercise and I gained weight. It must be muscle. False. That is a myth. Okay, and this is probably one of the most dangerous things we can say to patients is that it's growing muscle in the early stages of weight loss and beginning physical activity. It's just not the case. Growing muscle takes a lot of time. It actually takes consistent progressive overload. So let's look at a systemic analysis. This is the best publication actually out there. There's two actually from two research groups on maximizing muscle hypertrophy. If you want a crash course in how to grow muscle, I'd recommend you go check out this publication. It's written almost like a guide versus like a publication. It's excellently well done. What they conclude in here is that for muscle growth, muscle hypertrophy, 6 to 10 weeks, muscle growth becomes a dominant factor. Up until that point, it's not going to be a dominant factor. You beginning or a patient's beginning physical activity in the first week is not the reason they gained weight. It's not going to be because of muscle mass. Okay, and so if you put someone on a body composition machine, they begin exercise, you put them on next week, that's not going to be a favorable thing we're going to look at. We're looking at water fluctuations, we're looking at inflammation, we're looking at a lot of factors. There's even neural factors. You can be stronger within the first week or second week of performing physical activity, but that is neurally driven, not hypertrophy driven. Okay, and so keep this in mind. When we talk about our patients that are coming in beginning exercise, yes, we want to encourage and keep going, but muscle happens with progression and overload. Okay, there is some publications with very weakened and deconditioned individuals within 4 weeks, they see hypertrophy, but even then, that's 4 weeks. Okay, so keep it in mind. Now, other things to note with this, less than 60%. Do I lift heavy? Do I lift light? This is a common question I get. Doesn't matter. What we now know in the literature of muscle hypertrophy is you take the muscle to what we call volitional fatigue. Okay, so the point where you strain or you cannot lift another rep safely. Okay, that can occur with either light weights or heavy weights. Okay, we see muscle hypertrophy in that low rep range, that 5 to 8 rep range, and also that high rep range, 15 to 20 rep range. The more important factor that occurs in literature when it comes to hypertrophy is that the muscle goes to fatigue. Okay, so I always tell patients, find the exercise that you're safe and comfortable doing and can take the muscle to fatigue. It doesn't have to be sexy. The muscle doesn't know the difference. Okay, it's performing a movement pattern. What we see, 60%, 2 to 3 times per week. If you're doing less than 60% of your 1 rep max, 60%, think of it as a scale of 1 to 10, 10 being really hard, only getting 2, 3 reps, 6 getting that 10 rep range, 8 to 10 rep range, so it's moderately hard. If you're going less than that, 2 to 3 times per week, take the muscle to fatigue. If you're going greater than 60, you don't actually have to take the muscle to fatigue. Hypertrophy will occur 2 to 3 times per week. So resistance, those are the 2 recommendations. But this paper is full of great insights, so I encourage you to check it out. Okay, last question, then we'll wrap it up for today. To get to the group, what is the normal time frame for muscle hypertrophy to occur, muscle growth to occur? Three, 2, and 1. Yes, it is in that longer time frame, unfortunately. So unfortunately, not that easy to grow muscle. Not to say we shouldn't do it or improve exercise. And final results, Sarah, congratulations. Our host is the winner. All right, guys, I appreciate your time. I know we're right on time or just a little bit over. Feel free to shoot me any questions. I'll post my contact info. You can scan it. You'll have all my email or phone number there. My email is there if you need anything. I'm happy to help any way I can.
Awesome. Thank you, JJ. That was fantastic. I love the interactive piece of your presentation. I think we all learned a lot. So for sake of time, I think we're going to have to move on to the next presenter, but definitely please put all of your questions in the chat box and we can make sure that we try to get those. We'll get those to JJ so he can answer those. But thanks again so much for your time. Great presentation. I'd like to move on to our next presenter, Dr. David Sarwer. He is the Senior Associate Dean for Research and Strategic Partnerships and the Director of Center of Obesity Research and Education at the College of Public Health. He's a professor in the Department of Social and Behavioral Sciences. His research is focused on the etiology and treatment of obesity. Much of his work is on the psychosocial and behavior aspects of extreme obesity and bariatric surgery. He's published over 350 papers and book chapters based on his research. His research has been continuous funding from the NIH since 2002, and his scholarly productivity leaves him ranked in the top 2% of scientists worldwide. Wow, thank you so much for presenting today, and we're really excited to hear your presentation. So I'm going to go ahead and let you take it away. And again, if you guys have questions, go ahead and put those into the chat box. Thanks for presenting today.
Thank you, Sarah, for having me. I bet you, though, I'm not the only one who finds it curious that the moderator who had access to all of our presentations happened to be the one who had the most points on JJ's quiz. So
I don't know what to say.
Kudos to JJ. He did such a phenomenal job, and I love the way he brought all that interactive material into his talk. The problem now is I'm a dinosaur. So I'm an old school lecturer presenter. So I don't have any of the bells and whistles that JJ has. And then I was also challenged by the fact that I think my presentation in San Diego was about a half an hour. So I was challenged to really condense this down to about that 15 to 20 minutes to give us time for some Q&A. And I'll just start with some kind of general comments to set the stage here. We all know and agree that metabolic and bariatric surgery is the most effective treatment that we have for extreme obesity. We see those large durable weight losses. We see those improvements in health. But one of the things that my colleagues and I have spent a lot of time thinking about over the last couple of decades is what lessons can we learn and about that 20 to 30% of patients who don't have that predicted outcome, who either don't lose as much weight as we would have anticipated or have lost weight and regained it over time. And we've written previously about the different reasons for this, that in some ways maybe physiological adaptation has played a role, that our bodies just adjust to those postoperative changes. And in that toxic food environment in which we all live, people are just over time, many of them are gaining weight. Could it be that preoperative psychopathology, that patients who struggle with depression or anxiety or other mental health issues prior to surgery, that those issues are coming back around postoperatively and contributing to weight gain over time? Could it be disordered eating, and specifically things like loss of control eating or binge eating disorder that maybe are part of this pathway why patients aren't being as successful as we would predict or as most patients are? And then where we focused a lot of our work has been in this idea of poor adherence to the postoperative diet and the recommended behavioral program. So as all of us know who work in comprehensive programs, the entire team spends months training patients about what the postoperative diet is going to be like, encouraging them to change their behavior in advance of surgery when they can. But I think we often forget, if not discount, that those changes are hard. And just like JJ was saying about physical activity, they take time, they take commitment, they take consistency. And to do that in an environment where eating at large amounts of food and de-incentivizing physical activity is the norm, the way we see it in the United States and many westernized countries, it can be really hard for patients to do that for years or decades to come. So as we look to the future, my colleagues and I think there probably are 4 different avenues and 4 different areas where we can think about the role of adjunctive interventions to promote success after bariatric surgery. I am always struck by the fact that our surgeon colleagues spend a lot of time talking about revisional procedures. So if you do a bypass and it didn't work, if you did a sleeve and it didn't work, and the patient didn't have the response, their impulse, their instinct, and understandably so, is let's take that patient back to the operating room. And I would say, before we do that, maybe we need to really understand what's going on with that individual patient, understand what's going on with them, what's going on in their environment, to see if in fact there are other interventions that we can offer them. And I would say that for the purposes today, we're going to put them in these 4 buckets. So we're going to talk about pharmacotherapy, which the entire field of obesity is talking about week in and week out. We're going to talk a little bit more, as JJ did, about increasing physical activity and decreasing sedentary time, the role of lifestyle modification, and then a new version of cognitive behavioral therapy called acceptance and commitment therapy. Now, a lot has been written about the GLP-1s and where we're at in terms of anti-obesity medications. And as somebody who's worked in the field for just shy of 30 years now, it's an incredibly exciting time because these medications are coming with weight losses and health improvements that we just didn't see from the previous generations of medications. I myself kind of go back and forth about how I feel about these medications. A year ago, if I was giving this presentation, I probably would have said, I'm a little bit worried that the mass media hype is out ahead of the science. But now we're in the early part of or mid part of 2024, barely a week goes by that we don't see another major presentation at a national or international meeting, another major publication showing not only these impressive weight losses, but improvements in cardiovascular disease and diabetes control and cancer outcomes and fatty liver disease, that it's hard not to think that these medications have great potential as an adjunctive treatment after metabolic and bariatric surgery. And there are a number of investigative groups around the country and around the world that are looking at this very issue. Now, while I think this is really exciting, I think we also have to keep in mind there are a lot of logistical issues that still need to be worked out. So supply chain issues, and first and foremost, who's going to pay for this? So are we going to find a way in the United States that the costs of these medications come down so they're more affordable for people with extreme obesity who maybe don't have the financial resources to pay hundreds, if not thousands of dollars out of pocket every month? Or will the insurance companies step up and in specific cases begin to approve these medications? Because if not, we're going to be stuck at this standstill and these medications will never realize their full potential. So again, I think it's an incredibly exciting time. I suspect many of your surgeons and non-surgical medical colleagues are prescribing these medications. And I think we're still going to learn a lot in the next 3 to 5 years about those issues of access, affordability, long-term maintenance, and hopefully, we see their realized potential. So JJ just did a much better job than I'm going to do talking about physical activity. I'm very fortunate right now. I'm collaborating with Dr. Dale Bond up at the Hartford Hospital, who many of you know from the IH Committee, who has a new grant from the National Institutes of Health, not only looking at ways to increase physical activity, but as JJ mentioned, strategies to improve motivation. Because we know if we ask our patients, both before and after surgery, how active are you? They'll say, I'm pretty active. But if we put an objective measurement on them, like an actigraph, we find out that unfortunately, they're not as active as they say. So they report low levels of moderate to vigorous physical activity before surgery. But those objective assessments say that even with that weight loss and improved health, they're really not figuring out ways to increase their physical activity. So one of the things that Dale and colleagues are doing is figuring out a way to how do we tap into that inherent motivation, as JJ was mentioning, to get people to be more active. And can we get patients to remind themselves of some of the reasons that they had metabolic and bariatric surgery in the first place? When I do the preoperative psychovals on patients, I will often ask them very pointedly, what is the one thing you are looking forward to the most after surgery? And the most specific and frequent answer I would get was taking my children to an amusement park. Because either they had tried to do it previously and it didn't go well, they were hot, they were uncomfortable, they couldn't fit on rides, or they knew it wouldn't go well and they didn't do it. And sometimes reminding patients why they made this decision to go forward with surgery for their friends, their families, their loved ones might be a way to help promote physical activity in the long term as well. Now, a lot of people have said, well, what if we take those standard tenets of lifestyle modification for weight loss, things like caloric restriction, recommendations to increase physical activity, and behavioral modification strategies, and we apply those to patients after bariatric surgery? Now, it makes a lot of intuitive sense, right? Until we remind ourselves that so many of our patients have actually done these things over and over again. And in some cases, they know as much about lifestyle modification and healthy eating as we do as providers. So there really, in some cases, may not be much more to teach them. And in fact, the literature says when people have applied these interventions, those traditional interventions to patients, they've really led to minimal differences in weight loss between the active treatment condition and a control or comparison group. So they're not harming people, but they're also not promoting further weight loss and weight maintenance over time. And that's where many people in the field say, well, we need to start thinking a little more creatively about how we reach and connect with our patients. Were my slides not advancing, Sarah?
No, sorry, you were just still on the title, so I wasn't sure.
Oh, I thought I had control of the screen and I was advancing. I'm like almost done. So you guys are still not seeing this?
No, we see your very first slide, like the first intro slide.
Hold on. Did that change?
Yes, there you go.
Oh, all right. You know what it is? My two other screens were changing. So let me see how quickly I can get us caught up here. Hold on a second. I'm really sorry about that, folks. I assumed that my slides were moving.
That's okay. And we can have these available too.
That would be great. I'd appreciate it. So you seeing that remote delivery of post-op interventions?
Correct. Yep.
Excellent. Okay. So again, my apologies, everybody. I assumed they were moving. They were moving on my screen. I didn't realize it was the third screen that wasn't moving was the one that had the active presentation. So my apologies. And these slides will be available to all of you. So thinking of novelness, one strategy is obviously remote interactions with our patients. And we know sometimes that works really well, like with Zoom calls and technology. And sometimes when you get a dinosaur, the mouse, and say, go ahead and control, he doesn't always know what he's doing, and his presentation doesn't advance, and so you miss out on his slides. So we have to be mindful of that remote connectedness through e-health or m-health interventions has phenomenal potential, but a lot of our patients probably need a primer on how to do this appropriately and engage with us. But I think in particular for programs that have a large catchment area of patients who might be challenged to come back to see a dietitian once or twice a month or a mental health professional weekly, remote sessions really give us great potential. A particular focus is on binge eating and loss of control eating. And I know I'm running short on time, so I've got to pick up the pace just a little bit. We know that prior to surgery, a large number of our patients have binge eating disorder or engage in what we call loss of control eating. They feel like they just can't stop themselves at one slice of pizza or a handful of something. They just keep eating and eating and eating. And that these behaviors, both pre and also post-operatively, are associated with weight regain over time. And so a number of different investigative teams, namely Carlos Grillo and Valentina Veja up at Yale University, have been looking at interventions to help patients who report being, that loss of control after eating. And what they've actually seen is that while patients will say through this intervention, their loss of control eating improves, their weight doesn't seem to change. So the behavior changed, but the outcome that we really focus on so much of the time, weight loss, didn't change as well. And so we have much more work that needs to be done in this space in terms of understanding loss of control eating. And then finally, an area where I'm doing some work with Dr. Lauren Bradley at Rush University is in the area of acceptance-based, behaviorally based treatments. So think of acceptance-based treatments as a version of lifestyle modification, but now with a more cognitive element to it. And it goes something like this. Things happen. Bad things happen. Stressful things happen. And sometimes when those things happen to us, we lose focus on what it is that's truly important to us. We get caught up in the moment. So we're trying to eat less sugary snacks, and we're having a stressful day at work, and we're stressed and we're anxious and we're not really happy. And then sure enough, there's a surprise birthday party for somebody. And even though you try to avoid having that piece of cake, in the stress of the moment, you have that piece of cake, you feel horrible about it. You feel like, oh, there I go again. I can't control my own behavior. Acceptance and commitment therapy would say, things happen. You're going to go under stress. You're going to encounter a birthday cake in the office. What types of things can you do to make sure you maintain your focus on your larger goal of controlling your weight over time? And so Lauren and I have a new study that just started less than a year ago, where we're recruiting patients both in Philadelphia and Chicago who have regained more than 5% of their weight after surgery, and delivering this intervention to them via a web portal and via teleconferencing. So we're able to work with patients in our larger catchment areas. They don't have to come into our clinics, and we try to get them back on track through this behavioral intervention. And in some of Lauren's early work, she's had great success with this. So just to wrap things up and kind of go back to where we were, remember I started with this slide, but I've added a little bit to it. If we believe that it's physiological adaptation that's causing weight regain, well, maybe the solution to that, and that's the place and the role for the anti-obesity medications going forward. For patients with preoperative psychopathology, such as depression and anxiety and other psychiatric conditions, maybe the treatment intervention is a referral to the team's mental health professional. For disordered eating, I think those mental health professionals and those dietitians can play a role. But I also think that in general, we don't do enough with our patients who are struggling behaviorally. So when we identify and see a patient who is struggling with the postoperative diet, I think a referral back to the dietitian on the team or somebody local to the patient makes a great deal of sense. And then I would just finally end my remarks by saying, I really do think even with all of the challenges and the role that we often play as advocates for our patients to get them through that preoperative process, now is really the time where we need to start focusing more closely on helping our patients on this lifelong journey. So whether we're talking about the teenagers and the 20-somethings who are having this done, or our average patients in their mid-40s, we need to remind ourselves that our patients are living with their postoperative outcome for decades. And in this environment, we need to be in a position to support that lifelong success. So again, I apologize for the tech issue and the non-advancing in the slides. The dinosaur will own it, but we'll make those slides available to you, and I'll turn things back over to Sarah.
That was a great presentation. Thank you so much. And I love all the referrals as a dietitian to the dietitians and to the integrated health team. So thank you so much. Guys, just to let you know, the presentation is in the chat box. So you can get that right there in the chat box and have all these great slides. So thank you so much for your presentation. I'm going to go to Chelsea next, and then we'll open it up for questions for the both of you afterwards, just to make sure she has enough time to present. So Chelsea Johnson is a registered dietitian from Houston, Texas. She is a board certified specialist in obesity and weight management and a board certified bariatric counselor. She has years of experience in bariatrics, working in the clinical inpatient setting and as an outpatient dietitian, and is currently the bariatric coordinator at Memorial Hermann Cypress. So welcome, and thank you for presenting today, Chelsea. Excited for your presentation.
Thank you. I'm happy to be here. So today I'm going to be going over changes in bariatric nutrition care. I have no financial disclosures. So just to kind of overview, we're going to kind of go over some up-to-date information on this nutrition care when it comes to our bariatric surgery world. We're going to talk about the virtual bariatric nutrition and world, the current virtual state, social media, but then also kind of the other side of it, which is our virtual care, support groups, telehealth, and that kind of thing. So when it comes to virtual bariatric nutrition and just virtual bariatrics in general, I think we're all hyper aware that it is definitely a double-edged sword. Obviously, when it comes to the virtual world, there is an increase in resources that is available to the public, which can be good and bad, right? We have an increase in professional resources, but everybody also has a phone and a camera and an app and TikTok and everything. So anybody and everybody can put that information out there, and it's not always validated. One study I looked at did notice that Google searches related to bariatric surgery increased from 67% to 95% from 2008 to 2017. So that is now 7 years dated. I'm sure it's even more, but I think that just illustrates that the internet is where patients are getting their information before they even step foot in our offices. So like I said, we'll kind of go into two different arenas here. First, I'm going to talk about the social media virtual side, and then I'll kind of talk about the virtual telehealth support group side. So the first thing that I wanted to do was kind of just see what is out there. What are our patients seeing when they start on this looking into surgery journey? So I went to YouTube first. This is just screenshots of the homepage when you type in bariatric surgery and weight loss surgery. I know the language, but I think a lot of people still refer to it as that. So I wanted to see what was out there. First thing at the top, we've got some lovely sponsored ads. So we've got something talking about some lovely gut health. We have somebody talking about a magical chocolate. So that's amazing. I think we can all quit our jobs. They've solved the problem. It's magical chocolate. We can go. But those are sponsored. Obviously, we can't really alter those too much. They're paying a lot of money to have those put at the very top of the page. Then as you scroll down, there are some that are highlighted from health sources. So that was encouraging to me. They're from either hospitals or universities, actual reliable sources. And then you get even more as you scroll down, just an endless scroll of different videos. It is anything from educational videos to patient testimonials, patient vlogs, surgeon information, news segments, anything and everything you can imagine. That's what's out there for YouTube. Then I went to Instagram. Same thing, did those two searches, weight loss surgery and bariatric surgery. I just looked at hashtags for the sake of comparing numbers. Obviously, I know Instagram changes the algorithm and all sorts of things all the time. But this was just a good to give us a number of the just sheer volume that's out there. Bariatric surgery at the time I did this had 2.2 million posts. Weight loss surgery had 1.5 million. I think that was positive because obviously it seems that the language is changing towards bariatric surgery. So that's awesome. But again, that is millions and millions of posts out there. Then I did TikTok. Same thing, those two searches. 414,000 for bariatrics, 150,000 Again, just the sheer volume. There's so much information out there. What I found interesting about TikTok, and I didn't even realize this until I did this little experiment, is when you type in either of those, or you type in anything diet, exercise, weight loss related, this little pop-up comes up that says you are more than your weight if you're having questions, and then it gives you all these resources. So again, just kind of wanted to bring awareness to what our patients are seeing when it's late at night and they're starting to debate this and they start going through these different things. So then let's look at what the actual research says. So there's a couple articles when it comes to bariatrics and social media. The first one, this is from 2016, and it was just looking at the social media footprint. So it looked at Instagram hashtags, diet and fitness related, and then specifically surgery related. They found that those terms related to diet, fitness, exercise, weight loss outnumbered the surgery hashtags about 40-1. What's interesting about this is that that's almost proportional to eligible individuals that are having surgery too. So that's interesting that that still comes up even in our social media world. We can see that ratio. I think it's also really important to note that if you look at here, some of the hashtags that they looked at, things, unfortunately, like VSG problems, gastric sleep sucks, that negativity is out there too. It's not as many, but again, I think as practitioners, we just need to know that it is out there. And it's something that we need to warn our patients about too. So then I started to kind of look at to more, what is the research saying about the actual content? Is there anything evaluating the content? What's actually out there? This first one looked at specifically patient-tailored education for sleeve gastrectomy on YouTube. So they looked at a bunch of different videos. They used the global quality scale to evaluate. Not surprising, I think, to any of us, but they did say that most of the content was suboptimal. Next thing, they looked at just where was this information coming from when it comes to social media and bariatrics? Who's putting out this info? Again, I don't think it's very surprising to anyone, but the fact that we have this to confirm it, that it's private bariatric organizations that are putting out most of this social media information. And of course, they're recommending that more of the academic programs try to get more of that information out there. So that's kind of just in general our social media. Let's kind of pivot and talk about something that I know we all love dearly, which is Facebook support groups. So interestingly enough, there's also some research on these Facebook support groups. So this first one just looked at what is the content that's out there. So they looked at one Facebook support group. This was in 2016. So again, even I think way less than what is used now pre-COVID times. So I think this is just amplified. 1 month period on one Facebook support group, 6,800 posts and replies were looked at. So most of the time they found that people were seeking recommendations, providing recommendations, commenting on changes, lending support. Overall, they're finding that these groups obviously are helpful for that support, helpful for those physical and emotional accomplishments, kind of providing more of that anecdotal stuff to these day-to-day things for our patients. But again, just something that we need to kind of caution our patients on. Hey, here are the positives, but also we need to kind of be careful of the factual information. Because the next article I looked at the accuracy of these Facebook support groups. So this was specific to nutrition post in one of the Facebook support groups. And they found that over half of the information was either inaccurate or too ambiguous to even determine. So they found that there was 7% of posts that were completely inaccurate or completely inconsistent with our nutrition guidelines. 22% had both accurate and inaccurate information, and 24% that were too ambiguous. So overall, that 51% of basically potentially inaccurate things. So again, this just really highlights we need to warn our patients. They can be a useful tool for support, but when it comes to actual clinical guidelines and guidance, you need to come back to your providers. So now that we've kind of gone over all the social media side, let's pivot and talk more about that virtual health side. So one of the things that's obviously popped up a lot in more recent years is our virtual support groups. This is something that my hospital system has started doing since COVID. And there's both pros and cons, as we all know with everything. I think the biggest advantages we know from these virtual support groups is obviously the accessibility. the opportunity for more people to attend and participate, people that can't travel or that doesn't work with their work schedule or they have kids, they're able to kind of log into a Zoom a lot easier than actually coming to support group. I think a lot of people that are also kind of maybe more resistant to come to support group, a little more shy or introverted, are way more likely to join a Zoom than come to an in-person meeting. At the same time, we've also recognized some disadvantages. And this is something when I talk to other people, they're seeing the same thing too. Sometimes it's hard to lack that connection that you get in person. It's kind of hard to read the room. Obviously, I know I'm guilty of this, of having a Zoom on, but my kids are running around. So you're listening, but you're not able to participate as much. And then again, just reemphasizing those Facebook support groups, we just need to kind of warn patients of the lack of usual clinical information that's out there. So another aspect of our virtual nutrition is obviously our telehealth. Telehealth is something that is here to stay. We saw in March 2020, there was a 154% increase in telehealth use compared to March 2019. Obviously, I think we all know what happened during that time. But even still, as of July 2021, it's 38 times higher than prior to the pandemic. And I think especially when it comes to our bariatric population, as has been mentioned before, telehealth kind of helps decrease some of those barriers, right? A lot of times with our patients, they've got tons of appointments. Sometimes they're having to travel long distances to get to a bariatric center. So telehealth gets rid of those barriers, which is really great. Lots of studies have proven that telehealth can be effective as well. So it's definitely something that is beneficial when otherwise there would be no access or very limited access. And then when it comes to our specific nutrition virtual care appointments, as a dietitian, I think we all know this, but I also always have to put this little bullet in there that dietitian visits post-surgery are associated with improved outcomes. That is proven time and time again, including our weight loss and our lower rates of micronutrient deficiencies. Follow-up rates also tend to be higher when telehealth was offered. Again, kind of just reducing those barriers of access for our especially post-op patients. When it comes to insurance coverage with dietitian visits, this could be an entire week-long talk, unfortunately, but it varies. It's definitely improved since COVID. It's something that I know a lot of dietitians and companies are working on, but we're getting more and more of that coverage. There are tons of also just private practice, social media, bariatric specific dietitians that provide that support and education. I talked to a few of them before my presentation and kind of was just talking through everything. I think one of the things that was really great that they all said was that they recognize that importance of redirecting to the clinic or the surgeon if something's really sticking out to them, and redirecting, hey, you need your surgeon yearly visits. Like, I don't take the place of that. So I think if you are a practicing private practice social media dietitian, redirecting back to the clinic when appropriate is so vital. And really it's about that teamwork. As always, there can be disadvantages with our telehealth too. Again, kind of the lack of connection sometimes. I know that there are some horror stories, even myself have experienced with bad virtual visits. So I think if that's something that's happening, making sure you're implementing some sort of guidelines or boundaries with those virtual visits, just emphasizing, you know, hey, this is going to be a conversation. It's not just to sit and listen to me talk, and really kind of giving them that idea of what to expect in the appointment and to understand you need to be present for this. And, you know, if you need to set a wardrobe boundary or whatever that may be based on past experience, you can set those guidelines as well. So just some tips for success. I know we're getting close to time, so I don't want to read each of these off. Y'all will have this PowerPoint too. Again, you want to maintain that professionalism too. Make sure that you're able to be seen on screen, don't have any patient information visible. And I think something that's important too to help with that conversation that I have had to work on a lot is making sure that you're making eye contact with the camera, not looking at yourself or looking at what you're doing. That can kind of just make it feel more like a one-on-one appointment. I just also wanted to provide some resources for those virtual care. So there's a bunch of virtual care companies listed up there that provide dietitian visits virtually. And then these are some just bariatric dietitians that are on social media that are giving trusted advice. There's tons more out there, but this is something that if patients are asking for, I kind of guide them towards this because we know they're going to be on there. We know they're getting their information. So here are some trusted sources. takeaways. We always need more professional and academic sources in this virtual world. We want to make sure that we have those resources available to patients if you're not providing them yourself. And then again, just warning our patients of this online information and making sure to emphasize that their in-person team is available, ready to support and answer all those questions as needed to make them successful. And that is my contact information if you need. Thank you.
Awesome. Thank you, Chelsea. What great information. And it is interesting because everything has changed so much and we all have to mold and change during these times.
And mold quickly, unfortunately.
Yes. Yes. We probably have time for one question. We have 5 minutes left. Does anybody have a question that they would like to ask to either one of our presenters today? Well, maybe not, or maybe I could ask one. David, I love all of your referring to all the different disciplines and should see a dietitian and should see behavioral health. What about programs that are limited in staff? You know, anti-obesity meds, we're trying to add that to our program, but it's finding space and appointment slots. And do you have a way, do you prioritize patients or how do you make all that fit in?
Yeah, I do think that bariatric programs that are housed in large medical centers with a comprehensive team in-house are clearly better advantaged to provide this coordinated multidisciplinary care. I think in situations where maybe you have a very large catchment area or situations where, say, for example, the mental health professionals are not staffed at the hospital and you rely on letters from providers in the community, it may be a very worthwhile investment for the team, for the bariatric program to really meet those people in person, maybe have them over for lunch, spend some time talking about you know, what are you all looking for in the preoperative evaluation? When would those providers like to see patients postoperatively? You know, in the back decades ago, you know, there was a lot of discussion about whether or not the mental health professionals should in fact be required to be within the hospital complex and not rely on people in the community, in large part because sometimes you would get a letter from a mental health professional in the community just said, yeah, they seem fine to me. And obviously the issues are much more sophisticated than that. And that letter is a disservice to you as a program, and that letter is a disservice to the patient. So I think if you don't have that expertise locally, finding a way to cultivate those relationships and maybe, like I said, making an investment of meeting with them for lunch or having dinner with them and saying, let's talk about how you do what you do. Let's talk about what we need so we can refer back and forth as needed.
It's great, good ideas for sure. Thanks for communicating that. Communication is always the key, isn't it? Lots of thank yous, really valuable information, great presenters. I think we hit it out of the park today. So thank you guys so much for presenting. I know that we have some of the presentations in the web chat. We can, Chelsea, if it's okay with you, we could add yours as well.
Yeah, absolutely.
Yes, and all of this will be on the ASMBS YouTube channel if you'd like to rewatch it. But thank you guys so much for joining. Remember, we will have our networking event in September, so we look forward to seeing you all then. So, and at the ASMBS weekend. So have a good rest of your day.